Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Hi, everybody. Thanks for tuning in to this installment of the Turd Nerds podcast. We are diving into a brand new topic that really probably we can talk about for the next 10 years on a daily basis. And we're just going to do a good dive in healing up the mucous membrane. But before we dive in, we're kind of asking, we're giving a plea. We've been really growing our audience and growing our listeners, but we have not been growing our Apple Podcast reviews. And so if you guys are out there and you are listening to this and you are tuning in every 2 weeks and you are loving our content, we cannot explain how much posting Apple Podcast review makes a huge difference. It's the only way that people find us. They're really, right now, everybody's finding us just through word of mouth, which is amazing, but it really stalls out on all of our listeners. So if you've got 10 seconds, just click on your Apple Podcast, give us a review, and that helps people find us. Okay, now I'm done with the selfish prompt for helping us. Now we're going to help you. And we're going to dive into what do we know about mucous membranes of the GI and how do we heal them. And actually, Dr. Sand did a huge investigative reporting literature dive to figure out what
my side hustle.
She's got, aside from being an amazing doctor and somebody who does Maya and a mom. Dr. Sand, what do you know?
Okay, well, this is going to be a collaborative episode. We all kind of prepared in our own ways in terms of like just years of healing the gut or, you know, our specialties that we bring. But I was able to look through a couple things and mainly I'm going to be focusing on why it's important to heal the gut-brain axis, why cortisol levels matter. But let's dive in first to why we care in the first place about intestinal permeability. Any thoughts on that?
I have to say that I'm reading the book Cooked right now, and
You're always reading. Are you reading or listening?
I'm reading. That's why it's taking me a long time. I'm diving into basically chronic disease, and we know that virtually all chronic disease seems to have a component of inflammation, and that inflammation seems to be rooted to the epithelial membrane of the GI.
It all comes back to the gut. What? Once again.
So, before we dive in, does someone want to define what a mucous membrane is? What are we talking about?
Mucousy, goopy.
Well, I mean, I think so. In what we're talking about today, we're talking about the intestinal lining, and when we talk about gut barrier dysfunction and what used to be called leaky gut by the doctors who were smarter than everyone else and knew about this, but then were made fun of, and then now it's actually recognized as elevated intestinal permeability.
And they call it intestinal permeability,
right?
But it's basically leaky gut,
right? Basically, same thing. And so we're talking about where there's sort of like little quote-unquote holes in the tight junctions where there's supposed to be a separation between what's going through the tube in our gut and our bloodstream. But when you have intestinal permeability, you get this unfortunate mixing of antigens that our immune system shouldn't be seeing in that way. And it's been this whole link that's been found between intestinal permeability and most, if not all, autoimmune diseases, right? The gut-brain axis, hormone dysfunction, all of these things that are linked to things that are causing inflammation, leading to intestinal permeability and this unfortunate presentation of antigens
right
to the body.
And can we just have a really big picture view of why people get intestinal permeability? Can anybody think, do you want to drop some reasons of why?
Well, I think there's a lot of chicken and the egg here because I think certain conditions can cause it, but also gut stuff can cause it, and then you get all the systemic issues.
And it's all the big things we talk about, right? Like toxins,
inflammation,
food allergens, gut infections, stress.
Yep.
I also just want to say that our Western diet is almost
glyphosate.
Yeah. Our Western diet is almost created to give us intestinal permeability
Yeah, totally.
because of the pesticides, because of the glyphosate, because of the fact that we don't have any fiber in our food and we're highly processed sugar, which is inflammatory, and all the yeast and the molds. On top of that, the chronic stress that we're under and we don't sleep and it's like basically you're born in a time when it's really hard not to have intestinal permeability.
Yeah, so this is a really relevant episode is sort of what I'm gathering from today. Also, medications.
Oh, yeah.
Right?
Oh, yeah. NSAIDs,
sure.
steroids.
Yeah. Cancer medications, chemotherapy,
And then all the medications that we intake in our diet via pesticides and herbicides.
And I wonder about, Alana, you were talking about SSRIs. That potentially can have a link as well.
I mean, right now, the more we start digging for what pharmaceuticals and how pharmaceuticals affect the microbiome, the more we discover that pharmaceuticals affect the microbiome. Also, the more that we discover that medicine is so myopic that until you think of asking the question, you assume that it's fine. But when you actually ask the question and start researching, we start discovering that it's not really fine. And we've been basically waging a war against our microbiome and our epithelial layer since the Industrial Revolution.
Right.
So, bummer, guys. Sorry.
And I feel like I read stress by itself can cause elevated intestinal permeability, right? So we're basically all in trouble.
And then elevated cortisol levels.
Which is your hole that you're going to dive into.
Yep. Yeah, why we have to take
And so
it
you
into
can't
account.
fully heal intestinal permeability without addressing stress.
Well, I wouldn't recommend it.
Okay.
Yeah, you're going to get a lot further, I think.
I mean, you're probably going to spend more time, more money, and get worse results.
Plus, mental health matters. That matters. So, okay, things to consider when healing the gut axis. The causes we're looking at. Chronic inflammatory states. That includes things like inflammatory bowel disease. Other diseases, infections, HIV/AIDS is a big one known to do that. We have studies on that. Chemotherapy, radiation, other drugs, NSAIDs, alcohol. We didn't talk about that one.
It's a big one.
Goes with inflammation. Food allergies, like you mentioned, Emmy, and then cortisol. Anything else we want to add?
Do either of you know if biologics have been linked to intestinal permeability? I'm thinking of a few patients with IBD that I have who developed new food allergies after being on biologics.
So the reality is, my specialty is inflammatory bowel disease.
Yes.
And the reality is the data is very clear that biologics heal intestinal permeability because the issue with inflammatory bowel disease patient is that they have so much permeability followed by inflammation.
Right.
And we know as a fact the biologics cause, if it's effective, cause mucosal healing. Now, the immune system component,
different piece.
I think it's a different piece.
Yeah, I mean, because it's definitely helping them and they're in much better shape being on the medication, but they're also they've developed new food allergies, which I don't understand the mechanism
I
of.
think my guess, and I haven't done a data search, my guess is when you're dropping the lever of decreasing the inflammation and changing the immune system, the activity is different.
Yeah.
And so they're now shifting more towards Th2, which is more allergic. That would be my guess.
Okay.
Makes sense.
Yeah.
We'll see. Somebody will do a study on it, or they haven't. I just didn't read it.
Great idea. Okay, so why else would we care about this? Like, what other diseases do we know relate to intestinal permeability?
Basically all autoimmune disease.
All autoimmune, yeah.
Right, which is most illnesses that I think most of our patients often have one autoimmune disease.
And I don't even think it's limited to autoimmune. Like, I think I was just reading something recently that, like, cardiovascular disease is linked to, or just vascular
Metabolic
disease.
I think metabolic in general. We know diabetes.
Right.
Yep.
Chronic fatigue syndrome.
They're now calling, other
Alzheimer's,
dementia,
type 3
Alzheimer's,
dementia, type 3 Alzheimer.
I
or
also
type 3
learned
dementia.
asthma is another one.
that makes perfect sense.
Liver disease is pretty obvious, but worth mentioning. Fibromyalgia, there are studies on.
That makes all of this actually, like, when you think about it,
know.
it's like oh yeah, of course.
I know.
What I was trying to say a few minutes ago was type 3 diabetes. I said the three other.
Type 3 diabetes.
Alzheimer's has been described as type 3 diabetes, and there is this connection between.
Totally.
Yeah.
Intestinal permeability.
Should we just popcorn some of our favorite treatments?
I haven't heard that terminology before.
Really? Wow.
But it's a great description what we're about to do.
Wow.
I also had never heard of Banksy. Bansky?
Bansky, the artist?
I'm completely out of touch with pop culture.
We're
you guys
here for
know
you. We're
the
here
graffiti
for you, yes.
artist?
I mean, I
Okay.
do. I feel like we might need to infuse
Well,
some
my
Facebook.
friend Eva has named her dog, and I was like,
Bansky.
"Oh, that's an interesting name. I'm having a hard time pronouncing it still." Apparently
I
the
love
only one
that.
who has not heard of it.
Well, back to popcorn.
Okay, sorry, go ahead.
Okay,
And
so
popcorn.
I feel like there's the best place to start with intestinal permeability. And when I'm thinking about it, I personally am thinking about the small bowel.
Right.
Are you guys thinking about the small bowel or large
Small
bowel?
bowel.
Okay.
I don't know if it's a phenomenon in the large bowel.
So, okay, let me just explain why we're thinking about the small bowel. Because the job of the small bowel is to act as a barrier. You know, the stomach begins digestion and then things drop down into the small intestine.
Yep.
And the job of the small intestine is A, to have enzymes that are secreted that cut up all of the different proteins and fats and carbs.
Yep.
And B, have an epithelial layer where the stuff that's being broken down is not crossing into the body. It's staying within the lumen of the GI. And when you lose that ability, that's when the body's immune system goes funny because things are coming into the bloodstream that shouldn't.
Unregulated.
Right, because that's where the absorption is happening, whereas the colon is a whole different.
Yeah.
So I've only heard of it described in the small intestine, and that whole old lactulose mannitol test that can still be done for measuring intestinal permeability is mostly having to do with small intestinal absorption.
Can
or
we actually?
not absorption?
We should talk about testing.
Yeah, I would like to, but I mean, also that's why, to back up a little bit, the small intestine, that's why we talk a lot about this with our SIBO and SIFO patients.
Okay, so I used to consult from this company that is no longer around, but I used to sit on their medical board with 2 gastroenterologists. And one of the things that we were doing is we were coming up with a product that can, address intestinal permeability. Right. And, it was me, and then it was a really, really smart gastroenterologist for UCSD and a really, really smart gastroenterologist from Yale. And it was an interesting working environment, to be honest, because there was me who's like, yeah, herbs are fine, drugs are bad. Not always, but usually.
Yeah.
But you do prescribe a lot of drugs.
But I do prescribe a little drugs, but I'm very comfortable with herbs and nutrients.
Yes, and they aren't.
And this the UCSD doc was, I mean, he was like kind of in the middle, like he was a gastroenterologist.
We
but
don't
he was
get
like,
the training by any.
Right.
You have to learn it on your own if you're going to learn it as a MD.
And then the Yale doctor had, basically he took his understanding of safety with the pharmaceutical industry and was trying to apply it to the natural herbal supplement area, right? And he had just, it was a very eye-opening experience for me because there was so much fear.
Yeah.
On top of that, when we were putting together our product for intestinal permeability, one of the things he talked about is, it's like a huge topic, and really when we're talking about a permeable intestine, we don't even really know from a medical field what we're talking about. So basically, as of a couple of papers, depending on which ones you've pulled, they either list 3, 9, or 20 separate layers of the intestinal mucosa. And so when we're talking about intestinal permeability, it is exceptionally not clear what we actually define that as. We're doing a whole lot of data and a whole lot of research on it, but Western medicine, conventional medicine is very myopic, and they're just breaking down these layers into smaller and smaller and smaller pieces. So the take home to that is, if you ask a conventional gastroenterologist, there is no gold standard for testing. Right. We have testing that we use, and I think we should talk about what we're using, but is it understood to be the gold standard? No.
There's not really a gold. There is no gold standard.
Mm-hmm. So there's what Ami just mentioned, which is the lactulose mannitol test.
Which no one really does anymore, except in research studies. But you can do it, and it is available.
That is absolutely true. Nobody does it except in research. It's a very cheap test.
Yeah.
And I think some of our functional labs still carry it.
I think so.
But basically what you do is you introduce orally X amount of lactulose and an X amount of mannitol. Mannitol should stay completely within the GI tract, and lactulose should be cleared, or vice versa.
I'd have to look. It's been so long since I ordered it. And then you measure measure to see what's been absorbed versus excreted, right?
Yeah, basically you collect urine over a 6-hour period, and then you're literally seeing what has been excreted. So they think of that as an option. I think lactulose stays in the GI and mannitol leaves. I think that's how it goes.
Because we use lactulose as a laxative. Right, so I would think.
Yeah, I think that's what
I never fully thought it through. So
so that's one option. Another option is using a zonulin.
Right.
A zonulin can either be done with blood or stool. I use it a lot with stool. And that is looking for the active breakdown of tight junctions.
Because it quite literally is the protein that just falls off. What about anti-vinculin and anti-CDTB? Okay,
so that is more specific with basically foodborne illness, like anti-CDT. So what Dr. Sand is talking about right now is she's bringing up this test that used to be called, or maybe still is called, the IBS Smart Test. I think now Quest has a similar test. It's like running out of his patent. And that basically is looking at...
Is it covered now?
I've
only ordered on a handful of people that asked me for it. I typically am a minimalist with testing, but
yeah. So what that anti-CDTB basically is is a marker that goes up when you've had an acute exposure to the CDTB exoskeleton toxin of any foodborne illnesses like salmonella or shigella or anything like that. Right. So that's a marker that goes up and calms down. Anti-vinculin is when you're having a chronic exposure to a part of the smooth muscle, like basically you're having an autoimmune IBS. Mm-hmm. That's the anti-vinculin antibody. Right. Mm-hmm. The other test that we have that's out there is an LPS. Mm-hmm. And this is another one, I think it's really difficult to track down to use it clinically, but we see it a lot in studies. Mm-hmm. And when you have LPS being degraded, then that tells you there's at least acute intestinal permeability happening. It's also very, very important to remember that we expect the intestine to go through periods of being more permeable. Right. It's not supposed to be locked tight. There's supposed to be this flexibility because it is a living organism. Mm-hmm. And so that's the other weakness for all of these tests because we're only looking at a moment in time.
Right. So I guess I don't do a ton of testing for this.
I agree.
Because I see people who I already pretty much can guarantee have some permeability issues.
Right.
Like that's sort of the last stop on the train on what I'm doing with them.
I agree.
Right. I don't see the point in it because if they're having symptoms, they probably have elevated intestinal permeability. Right. And like you said, it's a moment in time. And we do know that, for example, if you checked someone's salivary cortisol from day to day, that's going to change. Mm-hmm. So if their cortisol is changing all the time from stress and whatever, and that changes their intestinal permeability, then who's to say like there's zonulin? Has anyone done a study? Like have they tested them every day for a month?
Right.
To see like what's the point in getting a single snapshot of it?
I just don't see the utility.
And Dr. Fasano said every time, even people who aren't gluten sensitive, every time anyone eats gluten, they have elevated intestinal permeability for a period of time.
Anytime you take ibuprofen.
So if they're doing any of those
right.
or eating a food they're sensitive to and don't know about, I guess it's just
allergies, I would imagine, cause it too.
Probably ingested allergens.
Right. Yep. So not terribly useful in testing, at least for us.
Yep.
Right.
And maybe that's just our population.
But probably very useful in the study segment, but that's not what we do.
Right. Yeah. So if someone comes in to my office with a positive study for some kind of leaky gut something, my question is why? Mm-hmm. What do we need to fix? Why do they have the leaky gut?
Right.
Or what else do we need to address? Mm-hmm. So, okay, let's back to our popcorn.
Okay, I would like to start.
Okay.
Because I feel like the beginning of every conversation with intestinal permeability has to be glutamine. Okay. It is low-hanging fruit. It is the So the intestine is this organ, especially the small intestine. It's the only organ in the whole body that eats from two sources. It eats from the bloodstream, just like every other cell in the whole body, but the majority of its nutrients come from the lumen, right? The enterocytes, or the functional cell of the small intestine.
That's so weird to think about.
It's really interesting. But the majority of its nutrients are coming from the lumen. It gets first pick. It's the most important cell, in my opinion. I'm very biased. But so glutamine is an amino acid that is actually the preferential food of the enterocyte.
Right.
Not the colonocyte. A colonocyte is the functional cell of the large intestine.
Totally.
Glutamine a little bit feeds colonocytes, but it really feeds enterocytes.
Yeah.
And so because of that, I feel like there's no conversation that we can have that doesn't involve glutamine.
So lots of glutamine. Mm-hmm. How are you picking dosing on that?
So the dosing that I've seen based on a couple of different studies is dependent on weight and is dependent on disease. Mm-hmm. So
like level of inflammation? Is that really what it's targeting?
So inflammatory bowel disease, I think there's data. I, of course, don't have these numbers off the top of my head, but, 120-pound adults, I'm giving them 9 grams of glutamine 3 times a day. Somebody with IBS, I'm giving them 5 grams of glutamine 3 times a day, assuming they're about an average weight. And so, I also feel like if you do a lit search on glutamine and intestinal permeability, there's so much data that is available.
Is it in vivo data?
Both.
Okay.
But like the IBD and the IBS studies were done on patients.
And are you doing that as a single intervention with patients so you can tell that's doing something versus doing like a combination of treatments? Like, have you seen specific clinical improvement, or is it more that you're assuming it's doing what it does in the study?
I am assuming what it does, that it's doing what it does in the study. And I will say that is one, if you dose appropriately, you really see clinical benefit.
And what kind of things are people telling you?
Decrease pain, decrease bloating, decrease pain, brain fog, increase bowel movements, like lowering the amount that they feel. That, what is healthy digestion? It's an organ that you don't feel.
Right.
You feel hungry,
You're not
you feel like
thinking
you have to
about it.
poop,
Yeah.
but the rest of it does its own thing.
Right.
And have you seen it make anyone worse?
I've seen that it has upregulated a very small subset of my patients' anxiety. I've definitely seen that.
Because the reason I've always been hesitant to use it very frequently is somewhere along the line I was told or read that it can make some forms of dysbiosis worse. But that seems contrary to most of the data you're discussing.
I've never seen that.
Yeah.
I've seen it heighten a small subset of my population. It will heighten their anxiety. What's interesting is it is not always the anxious patients.
Yeah.
But it basically, I think it feeds it can, if the pathway is not correct, go into the glutamate pathway.
Right.
And so I have seen that.
Okay, so
All right.
glutamine's a big winner. Quercetin, anyone?
I have a lot of experience with quercetin.
I had a hunch.
So there is one particular study that looked at resveratrol, and they looked at resveratrol for IBS patients, and I feel like I read the study so long ago. What they found is using resveratrol, which the most active constituent in resveratrol is actually quercetin, it's a bioflavonoid.
Wow, I did not know that.
Yeah.
I don't think I made that connection either.
Wow.
Yeah.
Resveratrol's my fave. That's my number one.
Yeah.
I see that
It's
work
because
really
of the
well.
quercetin.
Yeah. Wow.
Yeah, it's a bioflavonoid in there.
Mind blown.
Basically, if you use uber high doses for a short amount of time,
So, okay, hold on a second. I thought quercetin was just like onions, garlic extract.
berries,
Food-based.
Whoa. Because resveratrol's grape skins. Mm-hmm. Wow.
Or from Japanese knotweed,
Yeah.
which is what you're using.
which is what I use with patients. Well, which is what I've used more for other indications as well, but it has it's another source of resveratrol.
Amazing.
If we're honest, I think that resveratrol or Japanese knotweed is safer if you're using higher doses than quercetin.
Yeah.
Because there is data that shows the risks of quercetin in animal data
Right.
is if you're using high doses, which I do like to use,
Right.
it will cause benign tumors, especially in the kidneys. In the animal data, never in humans, but in the animal data. And in human and animal data, it does show to slow or to block conversion of T4 to T3.
I was going to ask about that. Yeah.
And so I do think resveratrol, I think the whole plant,
Which would be knotweed.
knotweed is a whole plant.
Yeah, so
And
that's why we
grape,
use-
resveratrol in grape,
That
that's
would
more
be
a
a
whole
whole-
plant
yeah.
than quercetin.
Interesting. So I really like resveratrol, and I learned from you, Alana, to give it a really high dose because the data showed you need like a loading dose to bring down inflammation and then do a maintenance dose. Resveratrol's kind of stupid expensive.
Especially at the high doses.
Yeah, and in some of my patients, I did the lower dose because they were like, I just can't afford this, and I'm like, some is better than none. It so did not work.
I
It
agree.
did not work.
I totally. So, and I do my loading dose for 2 weeks.
Yeah.
What are you doing?
Whoa.
It's 120 pills per bottle, right?
Yeah.
And
So 5 caps twice a day. And I've had a handful of people, probably actually only about 2 or 3, who at that high dose got an abdominal rash.
Huh. I've had people who at that high dose have diarrhea, or if they're
never
constipated,
seen
the best
that.
bowel movement of their lives.
I've never seen that either.
It's cost prohibitive to.
Wow. I tell all my patients you might get an abdominal rash if that happens. Take a Benadryl. Stop it.
I've never seen the
And
abdominal
resume
rash.
at the lower dose when it clears.
What do you see with Japanese knotweed?
Well, I don't really see side effects with Japanese knotweed.
What's the dose that you're
How
using?
are you dosing?
But I mean, we have capsules or liquid. It's more of that herbal blend that we use for chronic infections. So I don't have an exact dosing of like how much resveratrol is in it.
I feel like
but
I'm guessing
it's one
higher.
of the herbs that typically I don't see much side effects. Like it helps cognitive function. It helps. I haven't used it for the indication you're using it, but you could try it. It's much less expensive.
So what are you doing to heal the gut?
Okay, so we differ in our approaches.
Now we're getting down
most
to
of
it.
my mentors that I learned from, I am much more aggressive, I think, than you two about really trying to identify like potentially foods and allergens that are affecting the person's gut.
Got it.
If they're open to it, and going after like toxicity, detoxification, all those other root factors, to the point where, I mean, my main mentors didn't really think it was necessary to do this stage of gut healing. It was more like remove the triggers and the gut will sort of like take care of the rest, because it does the cells turn over pretty quickly, right? I mean, they regenerate pretty quickly. So I think what you're both doing makes sense. I've gone more the route of sort of like, let's identify as many things as we can that are causing the issue. And once we remove those, things typically will get better. And I don't necessarily do a targeted gut quote unquote healing protocol outside of food as medicine. Keep your all the other
fiber,
things.
drink some water,
and if they tolerate fermented foods, that type of thing. But I don't do a ton of I'm kind of like a minimalist in that piece. Like the less is more.
So you're not even giving oral like pill probiotics.
I will sometimes, but it's 50. The data is pretty 50-50, you know. And then there's
not
that
for
unfortunate
ulcerative colitis, but definitely for.
In general, there was that unfortunate study that one of the GI doctors published where it made cognitive function worse because of the D-lactic acid producing bacteria. Wow. It made brain fog worse. Yeah. So I'm always hesitant. I tell patients, like, it's basically literally 50-50 if it's going to help. There's no best one. We can pick amongst these 50 really good ones. And I've had patients where it cures their IBS, and I have other patients where it makes them worse.
Totally.
I tend to use more of the spore forming ones if I'm going to use them. Mm-hmm. Or if someone just tells me, I feel good on this, great. I mean, keep taking it.
I feel that way about Sac Boulardii.
I love Sac Boulardii.
That is one that has so much clinical research that, I mean, so many studies on it. But again, for whatever reason, I think a lot of my patients have allergic issues and they don't do great on it, or we don't get the effect that I'm like, this study's telling me this should work.
You know who says that too is Jill Krista. Jill Krista literally says the same thing. She says the data on it is so good.
It's amazing, yeah.
I feel like her population is a lot of mold. Yeah.
Probably,
you know?
yeah.
And,
so is both of yours, you just don't know.
Yeah,
it.
well, that's probably true. But she was saying there's basically this amazing animal study that looked at S. boulardii for these cows with mold, but it was in a very controlled environment where they really aggressively controlled their food. Yeah. And her theory is that I think that S. boulardii doesn't work because we're not controlling our patient's food. However, in my experience, I love
it works great, right?
It works. I love S.
And
boulardii.
Is it from lychee, which I really enjoy? Isn't it from the skin?
Know.
I feel like it's from the skin of lychee.
I don't know.
Which is an amazing fruit that you can get in India.
And also Thailand. Okay. And delicious.
And from the Asian
I don't know. I don't know that the way I'm using is necessarily addressing intestinal permeability, but I think back to your point about not really doing like a gut repair, whatever, so to say. I really feel like the gut repair I do after a SIBO treatment or some kind of small intestinal treatment is why I don't see a lot of relapse.
That's great.
And I tell my patients, like, if you're willing to stick with me through the end of like the protocol, including the gut repair section, right? I don't see a lot of relapse except in 2 cases: food poisoning. Mm-hmm. Well, I guess 3: food poisoning, a bunch of antibiotics, or if you have a hypermobility spectrum disorder.
I mean, I will say after I got the protocol from Dr. Sand, which is from Dr. Gurevich, or some combination.
I mean, I'm sure it's been altered, but
it did work great for the handful of patients that did have SIBO, and they did have recurrent SIBO, and we're like, let's just do everything we can do so this doesn't come back, and it did work amazingly well. I think for other forms of dysbiosis, I feel like I don't know if it has the same effect if it's post-protozoa, post-fungal, because those have different causative agents, but I don't know. I haven't used it recurrently in those patients. So
I also think if we're going to be talking about intestinal permeability, I think the other interesting compound to talk about is zinc carnosine.
Yeah,
which has great research from Japan,
research.
Right?
Yep.
Yeah.
It has great research for ulcers induced because of radiation, ulcers induced because of H. pylori. It has great research on ulcerative colitis. Mm-hmm. I mean, zinc carnosine, it's a chelate, right? So that basically what that means is they take a zinc molecule and they put it in the lab and they make a combination to make it this special other form, which is a chelate. And I do feel like I have very good...
I think it's my second favorite.
Yeah, I agree.
I mean, it's part of the whole gut healing protocol that you use, right? Post-SIBO with the...
I use it a lot in just gastric issues too. So
esophagitis.
Yep.
Yeah.
I would agree. I would totally agree.
Yeah. And I see it work great.
I think the challenge is when I've given it, it's been with other things, so I never quite know if it's the only thing. But it has good research.
It has
right?
good
pylori.
research.
Like combo heartburn products?
Yeah,
okay.
or just we're doing something where we're doing more than one thing. And so
Yeah.
I'm never quite sure just with that. Have you both used it singularly?
I have.
There's one product that has like a squeak of glutamine in it, but
Okay.
mostly zinc carnosine.
Okay.
Like I don't think it's enough glutamine to
No.
do anything, so
Yeah.
I assume it's really just the
And
zinc carnosine.
so,
And
you know,
you've
the
seen
data,
that
Yeah.
singularly work well
Yeah.
for
heartburn.
Okay.
75 milligrams a couple of times a day for the zinc chelate
Yeah.
or zinc carnosine. It worked great.
So can you tell me, because we've talked about this before, why you're not as worried about people taking that much zinc carnosine versus just like zinc other forms?
Because it's a chelate, which means that they've changed the active structure, which means it stays significantly more localized within the
so
GI.
it's not absorbed.
It's
It's not
not-
going to throw
no.
off your copper
And it's been being
levels.
used short term.
Yeah.
And I can say from like 10 to 15 years of checking people's zinc and copper levels with the normal zinc, I have yet to see someone's copper be thrown off by the 30 to 60 milligrams of zinc I've given them, even though I tell them this can happen and I want to recheck it in 6 months if we're going to keep going, because a lot of my patients have chronically low normal zinc, and to get them to the 80 to 100, I have to keep them on it. But I've never seen it suppress the copper. So theoretically it can happen, but I also don't use super high doses. There is a case report. So yeah, you do want to check, but with
I
that
just pulse
form,
it. I have people take a week off.
well, but if you're, some of these people, their zinc is in the 50s or 60s when I first test it, and then we get it to like 70s, and if
Yep.
we stop it, it drops back down. So
What's the
maybe that
goal?
means they need to do this gut repair protocol.
What's the goal for zinc?
I go with 80 to 100. That's not based on a study. That's based on like mentors passing down. This is what we
And
go
then
for.
what's the goal with copper?
80 to 100.
Interesting.
I mean, but I'm fine with the copper in the 70s. I just don't want the copper below the lab's normal range. I don't push it to a very
'cause
high
that's-
level.
That could be toxic.
But the zinc, I do try to get to the 80 to 100 range. I'm happy if it gets to 80. But a lot of people start significantly lower.
Okay, let's recap about everything we talked about with testing and supplements. Who wants to take a go?
Well, I mean, testing I don't see much utility with it. I just don't do it. I think you should spend your money on supplements instead.
Yep. Okay. And then let's recap on supplements. Here's what I got from supplements. Glutamine, there's data. Zinc carnosine, there's data.
Resveratrol.
There's data. Quercetin,
Quercetin.
it has a little bit of risk.
We kind of hit on probiotics a bit.
And that's
Anything
Thanks,
else?
guys, for joining us. That was a great episode. Please don't forget to rate and review us. It makes all of the difference.
Yeah.
Thanks so much.
Thanks for tuning in.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.